Good evening, everybody. My name is Edwin Maldonado, and I am the Community Engagement Manager for the All of Us Research Program for the Medical College of Wisconsin. We want to welcome everyone to tonight's presentation, which is sponsored by the All of Us Research Program. The All of Us Research Program is a historic effort to collect and study data from 1 million or more people living in the United States. The goal of the program is to better health for all of us in advancing precision and personalized medicine through research. A couple of housekeeping presentation points to mention really quick. Number one, we will have a disease overview. In other words, we'll be talking specifically about colon cancer and different parts of it. And there'll be a Q&A session at the end. If at any time you have any questions, please type those in your chat box or hold them for the Q&A when we come back at the end. Taquanda Gilbert will be monitoring the chat and taking care of notes and getting things ready for us. This presentation is being recorded, and the recording will be made available on social media through YouTube, Facebook, Twitter, and Instagram, and we'll provide that information at the end. You have been muted by the host, so please stay on mute unless you want to speak, and if you do, please mention it on the chat, and then we'll open up your microphone. And at the end, as always, we'll do a drawing for $25 at the end of the presentation. So again, today I mentioned the speaker is going to be Dr. Daniel Stein, who is a GI specialist, and I'm sorry if I kill this, gastroenterology. Here we go. And he's also the director of the Inflammatory and Bowel Disease Program at Froedtert and the Medical College of Wisconsin. So Dr. Stein, thank you very much. At this point, they're going to pass it on to you so you can begin your presentation.
Excellent. Thanks for inviting me here tonight. You'll be happy to know that I just had my in-person visit for my All of Us memberships. I signed up for the program myself, and they just drew my blood on Monday and did the blood pressure and height and weight measurements and all that kind of stuff. So
awesome.
I'm all in on this. So yeah. Sorry, let me back up to the first page of my presentation there. So, well, thanks for having me. You know, as some of you may or may not be aware, March is Colon Cancer Awareness Month, which I'm pretty sure that's why this topic was chosen. If you see people with little blue ribbons on their coats when walking around the hospital or just around that are in the shape of kind of almost like a little person, down here, that's the symbol for colon cancer awareness. So if you've seen that around, now you know. So, and so a lot of this is going to talk about what is colon cancer, how it develops, and what colon cancer screening is all about. And this is a presentation I've borrowed from the American College of Gastroenterology. They are one of our professional societies that focuses a lot on provider education as well as patient education. So they make this presentation available to gastroenterologists and GI providers every year this time, so that we can share with patients groups like the ones here today. So, you know, colon cancer is the third most common cancer in both men and women. Yet it is actually one of the most preventable types of cancer. Regular screening and removal of growths in the colon, which are called polyps, actually reduces the risk of developing colon cancer by up to 90% with colon cancer. And it's important to focus on the fact of preventable cancer, because that's an important distinguishment that we have from other cancers, in that, you know, there are other cancers out there that we screen for, as I'm sure some of you are aware, such as prostate and breast cancer with, you know, the PSA antigen or mammography. But colorectal cancer is actually the one that not only we screen for, but we actually prevent colon cancer from happening. Whereas with breast cancer and prostate cancer, the testing there is actually to detect an early cancer so that it can be treated properly. Whereas with colorectal cancer, we're actually trying to prevent a cancer. And how do we do that? Well, we do that by removing precancerous growths called polyps. And these polyps can grow into cancer if left alone. And screening and with polyp removal prevents colon cancer before it starts. And prevention is much more powerful than treatment. And so here's a little bit of what the colon looks like. This at the bottom, hopefully you can see my cursor, is the rectum. and this moves up into your sigmoid colon. This is your descending, or more commonly called your left colon. Your transverse colon, this will come across your mid-abdomen, and then your ascending colon comes down on the right side of your abdomen there. And colon cancer can happen anywhere along that line. Really, this is another statement saying that colon cancer and polyp removal prevents colon cancer. So what does it look like? So this is what happens, is that we get a kind of from left to right here, you see the progression of polyps here. And they typically start as small, benign polyps that then can grow. And the type of polyps that we worry about that can cause cancer are adenomatous polyps. There are a number of other kind of polyps, such as hyperplastic polyps, which are very common, and juvenile polyps. Those don't turn into cancer, but adenomatous polyps can turn into cancer, and they typically progress from very small polyps to larger polyps. They can develop to what's called dysplasia, or a precancerous polyp, and then you can develop an adenocarcinoma, which can be just located within the polyp itself and not invade it beyond the colon. And then this develops into colon cancer, where that invades into the wall of the colon and perhaps spreads throughout the rest of the body, if not caught early. So polyp is a small clump of cells on the lining of the colon. Most polyps are harmless, but colon polyps can develop into colon cancer. Not all polyp turns into cancer, but all cancers do start as a polyp. And polyps have absolutely no symptoms whatsoever, as do most colon cancers. So it's important to have regular colorectal screenings, such as colonoscopies, to look for these polyps. And remember, by screening, removal actually prevents the cancer before it even starts, which again is much better than just detecting an early cancer. So these are what polyps look like. They come in all sorts of different shapes and sizes. Here is kind of a flatter one. This one, I keep thinking this picture looks like a hippopotamus, not the kind of hippopotamus you want for Christmas, of course. This is a polyp which we call the pedunculated polyp. It kind of looks like a little mushroom or a little mushroom cloud. This is a flatter polyp where you see a little indentation here. And this is even sometimes you get really flat polyps, which are very subtle, where you can see the slightly redder part right there too. So that's what your gastroenterologist is looking for at the time of the colonoscopy. Some polyps are really hard to see. This is an example of a very flat polyp that just kind of looks like a bump on the mucosa. And then this is this big black thing. This is actually the endoscope, or the colonoscope, that we use. This is actually hooked back on itself like an umbrella handle, and is looking on the back side of a fold to look for one of these polyps. So while colonoscopy is very, very good, it can miss polyps, especially when they're hidden like this on the back side of folds. So again, reiterating the fact that prevention is key, and that colonoscopy is a powerful tool, and that we think that actually removal of polyps actually prevents up to 90% of colorectal cancers, and even more importantly, prevents the risk of death from colorectal cancers. So here, what does a colonoscopy look like? So this is your colon, where we pass, it's a flexible tube that goes through here, and we actually have a light on the end here, and there's actually several channels that run through here that we can pass instruments through that enable us to remove the polyps. Colonoscopy and polypectomy. So here's an example of how we would remove a very large polyp. So here's the polyp before we do anything to it. If you look at underneath this polyp, sometimes we'll inject some liquid underneath it to help protect the rest of the colon. And then what we do is we'll put a snare or a lasso around this, and that snare is electrified and provides some cautery that will actually cut through the base of the polyp, and it leaves kind of a spot just like this. And you can see here in the forefront, here's the polyp that's been cut away from the mucosa. You can see that there's that blue spot in the distance there. So that's kind of what it looks like. And this is an example of a very large polyp, but almost certainly this is a polyp that's an example that would turn into cancer if it was not removed endoscopically. So who is at risk for colon cancer? So colon cancer affects both men and women essentially equally. The lifetime risk for men is 1 in 23, and the lifetime risk for women is 1 in 25. So really pretty equal there. In 1990, estimates show that people born around 1990 have about twice the risk of colon cancer and 4 times the risk of rectal cancer than those that were born in 1950. And so what that stat means is that it seems that the risk of colon cancer is increasing. We don't really know why the risk of colon cancer is increasing. Perhaps it is an effect of some of the unhealthy diet and sedentary lifestyle that we have grown accustomed here in the US, but we really don't know for sure. Things that we know for sure influence the risk of colon cancer are certainly a family history. Just like almost every disease that you've heard of, a family history does certainly put you at risk. Having a family history of adenomas, so those precancerous polyps, puts you at higher risk. Cigarette smoking, obesity, interesting people have had their gallbladder removed, physical inactivity, people that have had radiation, so it's a less common thing to happen to most people. People that have had cancer of the uterus before age 50, so at a relatively young age to have uterine cancer. Patients that have a long-standing course of something called inflammatory bowel disease, which is comprised of ulcerative colitis and Crohn's disease. And then African Americans have a slightly increased risk of colon cancer compared to other races for reasons we don't fully understand. So what are symptoms of colorectal cancer? So I tell my patients that the top 3 symptoms of colon cancer are nothing, nothing, and nothing, which is why I think it's so hard to convince people to get screened for colon cancer, is that you don't have symptoms of colon cancer. And I will say that I've had patients that I've diagnosed with colon cancer that still were in complete denial of the fact that they did have colon cancer because they didn't have any symptoms. And it was a difficult thing for them to rationalize. So it's important to understand that colon cancer doesn't cause a lot of symptoms, often to its very, very late stages. So you don't want to ignore symptoms of colon cancer, such as rectal bleeding, new unexplained abdominal pain, or new onset of say constipation or something like that. What you really want to do is because the symptoms can be so variable, you want to reach out to your healthcare provider when you have new GI symptoms really of any kind. So really, should you wait until you get symptoms? Again, I think I illustrated there, absolutely not. You should not wait. Don't hesitate to talk to your healthcare provider about your symptoms. As I mentioned, blood in the stool, a new change in your bowel habits, change in the shape or style, or new pain, new pain, new rectal pain or abdominal pain. Sometimes a new unexplained anemia, which is a low blood count, is something that could be a symptom of colorectal cancer, as well as new unexplained weight loss. But again, these symptoms usually are associated with a lot of other disorders, so not always colon cancer. So I don't want you to walk away from this presentation thinking because you had a change in bowel habits that you might have colon cancer. But it is key to also remember, though, that some of these symptoms, particularly the anemia, can be a sign of a more advanced colon cancer, which is why it's so important that when it's appropriate time for screening, that you do get screened, despite not having symptoms. And so, again, reiterating, get screened even if you do not have symptoms. So screening in colorectal cancer, how do we do this? So number one, there are 2 approaches. There's the 1-step screening, and there's kind of the 2-step screening. And the American Gastroenterology College of Gastroenterology, explains the difference here. And oftentimes, at least in my opinion, it's best to get it done with 1 step at a time. So what's a 1-step screening? Well, 1-step screening is a colonoscopy. So this looks for polyps throughout your whole entire colon. At that time, your doctor can detect both polyps and remove them. except in rare cases. And when they remove those polyps, they're preventing the development of colon cancer, not just detecting it. And really, that's what provides us the long-term protection against developing colon cancer and from dying from it. What's the two-step process here? Well, there are some blood tests, there are some stool tests that can detect altered DNA in your stool in particular, as well as there are tests that can detect blood in your stool that would be a kind of an asymptomatic shedding of some abnormal DNA from a cancer or from an advanced polyp that would show this abnormal DNA. And this would prompt you to think that, oh, I might be at a little higher risk for having colon cancer. There is a multi-target stool DNA test, which does combine colon cancer with a FIT test. And this is your chance where you can get an increased risk of false positive, meaning that this test will more commonly be positive even when you don't have a cancer. But the important part here is that if you do have a positive test, the next step here is a colonoscopy. And really the FDA approved multi-target stool DNA test is called Cologuard. And that actually is a product that's produced right here in Wisconsin by Exact Sciences. But that is something that is actually FDA approved for screening for colon cancer. Again, if that is positive, you're recommended to follow up with a colonoscopy. So that's the two-step approach. Other tests that really aren't used very commonly. About 15, 20 years ago, there was a lot of excitement about CT colonography, where you'd have a CT scan that would look at the colon and look for polyps. This hasn't really caught on very well, particularly with insurance providers. And the other option is a colon capsule, where you would swallow a capsule that can take pictures of the lining of your intestines, and this would also look at your colon and take pictures to look for polyps. And this, again, positive test would be follow up with a colonoscopy. So another two-step thing. This is the usefulness of these tests are limited because insurances don't cover it very well. But still options out there for people that cannot have a colonoscopy, not get a FIT test, or are unwilling to do either. So one-step test is a review colonoscopy. You can see everything. You can take everything out. You can remove the polyps, test the polyps, and then you don't have to worry about doing two different tests. Whereas the two-step process, where you do the FIT testing or the multi-target immunochemistry test, these are often followed up by a colonoscopy once you have a positive test. So the newest guidelines, which actually were just recently published here, show that the American College of Gastroenterology, and this is a change from prior recommendations of age 50, is that they're now recommending that all individuals at age of 45 to 75 undergo a colonoscopy or some sort of colon cancer screening to reduce their risk of colon cancer and colorectal cancer death. The decision to advance beyond 75 is up to you and your doctor. Depends on how healthy you are at age 75. They do recommend that either a colonoscopy or a FIT be the primary methods for colorectal cancer. And then following screening individuals that are unwilling to undergo colonoscopy, that you could consider things such as a CT colonography, a sigmoidoscopy, or a colon cancer. But again, these are much less common approaches nowadays to screening for colonoscopy. The recommendations that they do the following testing is that you do a colonoscopy about every 10 years for somebody that is not found to have polyps, or we do the FIT testing once a year. If one of these alternatives is used, this is the testing schedule they recommend, whereas they do the Cologuard test, which is the multi-target stool DNA test, every 3 years. You can do the FlexSig, which is the limited colonoscopy, every 5. the CT colonography every 5 years as well, and the colon capsule every 5 years. But again, those are lesser used tests, and they actually recommend against doing the blood testing right now. That's not quite well studied yet. Important for African Americans is that African Americans are diagnosed with colorectal cancer at a younger age than other racial groups, and they do have a decreased survival compared to other racial groups. And we don't really know why that is entirely, whether it's genetic, but the recommendations for a little while now have actually been to screen African Americans at age 45 rather than age 50 before we move to everybody. Important thing to know about. So again, everybody age 45, colon cancer, or start screening for colon cancer. Family history of colon cancer. This is probably more important than anything we've talked about, but if you have a family history of colon cancer, particularly you need to talk with your healthcare provider about doing this sooner. If you have a strong family history, meaning several first-degree relatives with colon cancer, this should be done even more frequently, and maybe even genetic testing should be considered. Getting a screening test scheduled. Well, here you go. Here's some findings here on. You can find a gastroenterologist here on the website that is provided by the American College of Gastroenterology. You can also easily find this on the Froedtert website as well too, with links to our GI lab. You know, the important part here is take control of your health and getting screened. You know, make a plan. Bring this up with your healthcare provider if they haven't brought it up to you and you're age 45. You know, I think the recommendations for age 45 are a new thing, so your healthcare provider may not be aware of that. So if you are over 45, it is important to discuss how to get screened for colon cancer and what your preference would be. You know, as a gastroenterologist, I want everybody to get a colonoscopy, but realistically, it's doubly important that everybody gets screened for colon cancer in some way. Again, really, there are no excuses for this. You really should get it done. So again, remember, your excuse to avoid a colonoscopy is I feel fine. Remember, colon cancer does not have any symptoms. You know, again, I tell my patients the top 3 symptoms of colon cancer are nothing, nothing, and nothing, but before it becomes more advanced. And the earlier you catch a polyp or earlier you catch a cancer, the much easier it is for us to remove it, as well as the more likely it's going to be curable. You know, the other excuse we hear is I'm healthy, why get screened? Well, you know, that it surprises us all the time doing this, is that, you know, when we do colorectal screening and polyp, we find a polyp and we remove it, and we prevent that from becoming colorectal cancer. And we'll find these polyps in as much as 30% of our patients on the first time screening of their colonoscopy. So even though they're having completely asymptomatic. The other excuses that we hear is nobody in my family has ever had colon cancer. You know, that is not the only risk factor it is. You know, don't be the first one in your family to get colorectal cancer. You know, roughly 1 in 5 people are destined to get colon cancer. Sorry, about 5 in 100 people. So 1 in 20 to 1 in 25 people are destined to get colon cancer in their lifetime, even with no family history. So just because you don't have a family history doesn't mean you shouldn't get screened. What's your other excuse to avoid colonoscopies? I have no risk factors. Well, really, you know, the single modifiable risk factor to prevent colon cancer is failure to be screened. You know, to prevent your risk of developing colon cancer, the best thing you can do is have your colonoscopy or some sort of screening and have those polyps removed early. The other excuse we hear is only men get colon cancer. This is only a disease of men. Well, you know, it really is an equal opportunity disease, and women have essentially the same risk as men. There's a slight decreased risk of colon cancer in women compared to men, but the difference is extremely small. So women need to get screened just as importantly as men do. So with that, thank you for joining me tonight. I'm here to answer some more questions. Hopefully you found that that useful. I think Edwin, I think stop sharing my screen there.
There we go. I keep forgetting to unmute. Sorry about that.
Yeah, we've all been there, man. We've all been there.
I'm talking to the screen and it's not responding, so sorry about
If you
that.
haven't done that in 2020 and 2021, you just haven't been living.
There you go. There you go.
Yeah.
So at this point, Taquanda's going to pick up some of the questions they might have had. So.
Okay. Well, let's get started with the questions. And thank you again, Dr. Stein, for your presentation. So our first question we have is, how can research like the All of Us research program help in the study of colon cancer?
Well, that's a good question. I'm not a primary investigator with the All of Us, but you know, I think large group of banks of patient cohorts like the All of Us campaign are going to enable us to really identify some of the risk factors for people that develop colon cancer. So as All of Us moves forward, there are going to be those of us in the program that are going to, you know, unfortunately develop colon cancer, and we'll be able to look back with some researchers that are much smarter than myself to look back at some of the blood and samples that we've had and see some of the lifestyle choices that those patients have made in kind of in real time with more accurate recording to really be able to see so that people in the future and doctors in the future can advise their patients to avoid those kind of things to hopefully avoid colon cancer.
Okay. Moving on to the next question. How quickly does a polyp grow or become a cancer?
Well, if you start at the very smallest polyp that I showed you, which essentially all cancers actually start at a very small stage like that for the average person, and I'm not talking somebody that might have a genetic or particular family history of colon cancer. I tell patients that the rule of thumb is about you'll get 10 if you take 10 polyps, it'll take about 10 years for 1 in 10 of those polyps to turn into a cancer. So they don't grow at a very rapid rate in most individuals, which is why we're able to spread out the colonoscopies by 10 years in patients. So it's not something we have to do yearly or every other year like mammograms and things like that, because they don't tend to grow quite that fast. So that's about the 10 line I tell you. For people that have a genetic or a family history of colon cancer, some of those polyps will grow a little faster.
Okay. Moving on to the next question. Your thoughts on the relationship between the gut microbiome and colon cancer?
Well, that's a big question. Well, it's a short question, but probably has a really big answer, and it's one that we're just starting to understand. I think certainly the gut microbiome is something that definitely plays a role in the setting of colon cancer. You know, when you look at some of those risk factors I shared with you, like smoking and obesity and a sedentary lifestyle and stuff like that, we know that those are things that have an effect on the gut microbiome. So this is something that likely has an effect. You know, there are some studies looking at this right now. We are unclear, and we really don't know enough to really say like what the actual microbiome. There certainly haven't been any studies looking at things like probiotics or like fecal transplant and stuff like that you've maybe heard of in the news for other disorders in terms of treating colon cancer. But there is some role to be played with it. That one is not fully understood and is an incredibly complex subject.
Yeah. Okay, our next question. If you have a history of colon cancer, how soon should your children be screened?
That's a very good question. So what the recommendation is that if you have a first degree relative, so not just your children, but also your brothers and sisters and so on. So let's say you're 45 years old and you get diagnosed with colon cancer. It's recommended that your children get their first colonoscopy 10 years before that diagnosis of colon cancer. And the same thing would apply to your brothers and sisters. Certainly applies to your parents too. They're obviously going to be older than you, to get screened for colon cancer too. So if you have a first degree family member with colon cancer, it's 10 years before their diagnosis. So, so yeah, that's a very good question.
Okay. If a polyp is detected, does it need to be removed quickly?
Yeah, I mean, that's the benefit of colonoscopy is that when we see a polyp, it's rare that we leave polyps behind when we do colonoscopy. There's only some special situations where we do that, but that's the whole point of doing a screening colonoscopy is when we do see polyps, we take it out right away. There are rare cases where the polyp might be very large, where, you know, I would refer my patient to a specialist gastroenterologist who does some additional training in removing very large polyps, where that polyp we would bring you back in a few months. But for the most part, we remove the polyps right away, unless there's extenuating circumstances like the patient's on anticoagulation, they can't stop or something like that. But we try to remove it as soon as possible.
Okay. If you have colon cancer, should you have radiation therapy or chemotherapy?
Oh, well, that is a complicated question because that does involve how advanced your colon cancer is. So if the colon cancer, put it as simple as I can, if the colon cancer is just limited to the colon, most of the time that can be treated primarily just with surgery and surgery alone, where you'll remove that section of colon and take out the cancer and leave it alone. If it's clear from the onset that the cancer has spread either into lymph nodes within the belly or to the liver, which would be the most common place for the colon cancer to spread initially, then sometimes they'll do a combination of most commonly chemotherapy, perhaps radiation therapy, more commonly in rectal cancer, which is the very low down colon cancer. And then they'll combine that with surgery to follow that up. So it kind of depends on how far along the cancer is when it's found.
Okay. If someone had anal cancer, what are the probabilities of getting colon cancer?
There's not a big association with that, and the reason for that is that the anal canal, for the most part, and particularly anal cancer as we know it, actually arises. So in your anus, that's actually where the outside world, your skin, actually meets the lining of the colon, the mucosa. So it's a different kind of tissue that your skin is made up of than what the mucosa or the lining of your colon is made up with. So it's actually a different kind of cancer, and so it's treated differently than colon cancer that we talked about today. So while it certainly seems like it seems logical that they would be very similar, they're actually different, and they arise by a slightly different mechanism than by the way we talked about colon cancer. But that's a good question.
Is there any difference in the various prep methods out there? So I'm guessing prep methods before like a colonoscopy?
Oh, yeah. So talking about colonoscopy preps, for those of you that haven't undergone a colonoscopy, you have to drink a large volume of liquid. It is a pretty salty solution that basically flushes your whole system out, and that cleans your colon of stool so that we can actually see the walls of the stool. There are a variety of different methods. The most common one out there is Go Lightly. There are a number of other preps in terms of the one that we use now is what's called a split dose prep, where you'll drink half the prep, and then later on you'll drink the other half of the prep that you finish 4 hours before your scope, and that's because that's been found to give a better prep. So the better job you do on drinking the prep, the better job we can do finding polyps. So there are a number of different preps. There are some pills out there and those kind of things that do have the potential for some kidney complications that we don't use routinely, just because the older our patients, that we have are more likely to have kidney issues as people get older, and that's kind of the population we screen. But those are some people that we'll use for those kind of preps. But unfortunately, it's still a pretty large volume of prep, and not the most palatable thing in the world. But people are working on making it better.
Okay, and leading on to the colonoscopy topic, getting a colonoscopy, is it a one and done type of situation, or should you get them over the course of years?
Yeah, most people with average risk that don't find anything, we recommend you do it every 10 years. Because colonoscopy is very good at finding polyps, but the smaller the polyp is, the more likely we are to miss it, because as I showed you, sometimes these can be hiding out on the back of folds and that kind of thing. The polyp is can be missed. So, but those polyps, when they're very small and are missed, they take a long time to turn into cancer. So waiting 10 years is not a big deal. People that do find polyps, we actually recommend 5 years, and if we find a lot of polyps, we might recommend 3 years, or even a very large polyp, it might be a 1-year follow-up colonoscopy. Unfortunately, it's not necessarily a one and done. I'd like to be able to tell you that it was one and done, but unfortunately it's not.
Okay. Is colon cancer more predominant based off your race?
Yeah, it does look like there's an increase in African Americans having more likely to develop colon cancer. And for several years now, we've recommended that a couple of sites have recommended that the African Americans get screened at age 45 as opposed to age 50, which would have been the recommendation in the past. Again, this is something we don't know why it is. It just is something that's more common that we don't see in other races. But it looks like actually probably as a whole, Americans as Americans as a whole have caught up to the African American race now, and it looks like we're all probably at about the same risk now of developing colon cancer.
Okay. Then I have one more question. Can someone with IBS develop colon cancer?
So just so everybody knows, IBS is what's called irritable bowel syndrome, and this is something where people have symptoms such as abdominal pain, diarrhea, bloating, really a pretty mixed bag and wide variety of symptoms that those patients can have. But us as doctors aren't able to find an overt cause for it, such as inflammation in the bowels or a cancer or something like that. And that is generally a benign condition, and patients with IBS do not appear to have an increased risk of colon cancer over somebody without IBS. So it's a pretty benign condition. IBS patients should still follow general colon cancer screening guidelines like an average person.
Okay. Now, do we have any other questions out there? I mean, you can always put them in the chat or in the Q&A area. And if we don't have any more, Edwin, I'm going to pass it over to you.
Sounds great. Well, Dr. Stein, thank you so much. Okay, I'm just making sure I'm not muted. There we go. All right. I'm not going to do this again. Anyway, thank you so much for information. Just to back you up, I'm 62 and I've had several colonoscopies and gotten checked, and they're not painful. Pretty much when I wake up, it's kind of like you're done, it's over with. But just knowing that I got checked it just makes me feel better, because colon cancer does run in my father's family. So I decided just at an early age just to be safe and get checked. And thank God nothing's happened. Everything's been clear. But I do recommend everybody, if if you think you might have it, don't think, just go and get tested. It's the best way to do it. Go see a specialist, call your doctor, let them know what your symptoms are, let them know you're concerned, and they will definitely recommend you to get in there and get tested just to be safe. I'm not going to say it's uncomfortable, but I'll tell you, just knowing that where you're at is just comforting itself, knowing that you got a good idea of where your body is. And especially like when you mentioned also, doctor, there that it's changed with the generations, which is kind of like maybe basically it might be like you mentioned dieting or what we eat and whatever. Because before you were in an older age, now the age is bumped up to 45 for testing. When I remember it was up to 55, and little by little it's been going backwards. So that just tells us that just because our grandparents didn't have it doesn't mean we can't have it. It just means that we are more prone to probably have the symptoms. So again, thank you so much. I've learned so much from this, and I really want everybody just to encourage everybody, please get tested, be safe. Better be safe than sorry, as they say, and go from there. And again, on behalf of all of us, we thank you, Dr. Stein, for your presentation. And if anybody wants to see it again, it will be posted on Instagram, Facebook, and YouTube also. And I'm sorry, I keep missing the camera. I just had my computer readjusted, so everything is different than I'm used to. Please feel free. So right now we're going to have the drawing like we mentioned before. We're going to have a little drawing. I've looked at the attendance roster to see who's here and make sure I don't repeat winners every time. So I'm only going to give out the initials. That is it. And then we will confirm with you via phone or email within 48 hours. Once we reach out to you, you'll have 2 weeks to respond so we can make arrangements to get you the $25 prize. So the initials I'm going to be looking at here are PS, PS, just like it says there. So if your initials are PS, you may be a winner. You will be contacted within 48 hours via email or via phone to let you know if you are a winner or not. And
Edwin, that was P as in purple, not
yes.
P as in dog.
Yes, thank you. P as in purple.
Darn it.
And S
I
like
just
in
missed that.
and P as in purple and S like in sausage. So that'll help out a little bit more. Thank you for clarifying that. So if you are the winner again, we will contact you in the next 48 hours. And again, thank you so much. And like I mentioned before, we have a couple more sessions coming up. We will be presenting this session again in Spanish in 2 weeks. We don't have a speaker chosen yet, but we're in that process right now. And then for the month of April, we will be talking about liver disease. So please keep up with us. If you are interested in getting a copy of our calendar, just contact us. My name is up there, Edwin Maldonado. Our phone number here at our office is 414-955-2689, or you can go to our website at allofus@mcw.edu. We are on Facebook, Twitter, and Instagram, and you can go online in any of those sites and find out more. If you're interested in learning more about the All of Us Research Program, please go to joinallofus.org/Wisconsin, and then you can see our sites and take care of that. Again, thank you so much, everyone, for this time. Dr. Stein, again, thank you also for presenting. Great presentation.
My pleasure. Thank you.
And if there are any other questions you might think of after the presentation, please call us with those questions. We'll get the answers and we'll post them at the same time that we post the presentation on YouTube. Again, have a great weekend. Stay safe, stay healthy, and have a good day. Thank you so much, everyone.
Take care. Thank you. Have a good day.
Thank you. Okay, bye-bye.